مساء الخير حضراتكم جميعا. نبدا السيشن بتاعتنا النهارده. انا احمد كردي، ليكتشر اوف انديميك ميديسن، و اسف وانا coordinator of قصر العيني HIV and viral hepatitis fighting group, and it's my pleasure to be today with my professors in this very elegant conference to talk about the GI infections. I think my duty today is to give an overview about the gastrointestinal infections, diagnosis, and management. And the objective is to convert the theoretical knowledge that we know about the infections, which is usually difficult and hard, to something which is easy and helpful, like a practical knowledge that we can use in our practice, not only theoretical background. It's important to talk about the GI infections because it is responsible for very high morbidity and mortality worldwide, and the diarrhea, which is the most common symptom of the GI infections, is a leading cause of death in many of the resource poor or limited countries. To give an overview, we will have to talk about the liver, biliary, peritoneal, and bowel infections. Also, we have other infections that we have to pass through. Let's start with the liver-related infections and the biliary infections. I think we have to talk firstly about the pyogenic liver abscess because it is the most common type of the visceral abscesses. In one of the reports of more than 500 cases, they found that 48% of the visceral abscesses and about 13% of the intra-abdominal abscesses were related to the pyogenic liver abscesses. Usually there is a risk factor from underlying hepatobiliary, pancreatic, or liver transplantation, and also the diabetes is one of the most important risk factors. The route of infection may be from biliary source, vascular source, also from direct inoculation of the infection, but also we have to know that about 30% of the cases will be cryptogenic without identified source of the infection. The causative organism, we have a wide range of the pathogens that may cause the primary liver abscess, ranging from the Streptococci to Staphylococcus aureus to Candida species, and also the Streptococcus pneumoniae and E. coli now is one of the important emerging causes of the primary liver abscess. For the diagnosis, we have to make what we call a combination between the clinical picture from the fever and abdominal pain, also proper history taking, and also we have to take care of the radiology because now the ultrasound is one of the point of care tests that we can apply to our patients in the clinics. But please don't forget about the blood culture because it is positive in up to 50% of the cases. But we are not waiting for the culture to start the treatment. We have to combine the drainage and the empirical antibiotic therapy for the treatment. For the drainage, it is indicated to be percutaneous needle aspiration if it is smaller than 5 centimeters, and it is more than 5 centimeters, we have to go for the catheter drainage. And for the multilocular abscesses, the surgical drainage will be indicated. And to select an empirical antibiotic therapy, we have to make something that's working against the gram-negative and anaerobes. The first choice usually the ampicillin sulbactam, piperacillin tazobactam, but also we have alternative options in the fluoroquinolones, and also the moxifloxacin is one of the important fluoroquinolones because we have recent data about that it have gram-negative plus anaerobic activity, so it can be a monotherapy like the carbapenems from imipenem, meropenem, and ertapenem. But keep in mind that the treatment duration should continue for 4 to 6 weeks. Another important liver infection is the amoebic liver abscess, which is the most common extraintestinal manifestation of amoebiasis, and it is usually there when there is affection of the cell-mediated immunity. Also, the diagnosis is combination between the radiology and aspiration and examination for the Entamoeba histolytica trophozoites. Either it can be detected by the conventional microscopic methods or by the advanced PCR methods. And you have to keep in mind that for the location of the amoebic abscess, it's usually in the right lobe, in the posterior aspect. In more than 80% of the cases, it is isolatory. And you have to know that the serology for amoebiasis is very specific. We have about 90% specificity for the diagnosis and 99% sensitivity to diagnose the amoebic liver abscesses depending on the serology. For the treatment, you have to combine between the tissue anti-amoebic medications with metronidazole, tinidazole, and nitazoxanide, plus the luminal agents like the diloxyrinate for the elimination of the intraluminal cyst to avoid the spread of the infection in the community. And here, I think that the choice for doing drainage, it is only for the abscesses that is from 5 to 10 centimeter using the percutaneous needle aspiration, and we using the percutaneous caster drainage for the abscess that is larger than 10 centimeters. Also, we have a wide range of other hepatic infections like Brucella, Bartonella, Coxiella, Leptospira, and it is usually causing a systemic illness, so you can diagnose it as a part of the systemic diagnosis using the blood cultures. Here is an overview about the specific medications for specific causes, like doxycycline for the Q fever and benzodiazepine penicillin for the syphilis and other causes. Also, we have to keep in mind that the hepatic tuberculosis is one of the important GI infections or hepatic infections, but you need to know that it is not that common. And also, you have to know that usually it is a miliary infection, so the patient may have another laboratory abnormalities on top of to have anemia. And for tuberculous hepatitis, usually presenting with unexplained fever with or without mild jaundice, there is maybe caseating or non-caseating granuloma in the liver biopsy. And I think it worth to say here that by the end of the FUO algorithm, we are usually ending to go for liver biopsy or for empirical anti-tuberculous therapy for this cause, because the hepatic tuberculosis diagnosis is usually challenging. Because the Zell-Nelson, for example, staining for the tissue sections, it demonstrates bacilli from 0 to 45% only. We can make use of the PCR techniques for the diagnosis of the bacilli and the tissue. Also, the pathological examination can help us in the diagnosis, but please also keep in mind, we are not searching for caseating granuloma. The non-caseating granuloma is enough for diagnosis of TB if all the clinical situation going with the diagnosis of TB. It may be miliary or local TB. For the miliary TB, usually it's from a source is hematogenous from the hepatic artery. It's causing multiple disparate and low density micronodules. And for the primary hepatic TB, it is coming from the GI system through the portal vein. So it's causing large low density nodules with calcification and peripheral enhancement. For the treatment, we are following the same treatment regimen for the pulmonary TB, starting by 4 regimens from rifampicin, isoniazid, ethambutol, and pyrazinamide. And sometimes when we are not able to use the pyrazinamide for hepatotoxicity, we also may be able to use the moxifloxacin or another quinolones as an institution for the pyrazinamide. Then we can continue for 4 months using the rifampicin and isoniazid. The duration for treatment, it is controversial, but usually it is from 6 to 12 months, not more than this. Hepatic brucellosis, also another important infection that may affect the liver, and usually the diagnosis based on the diagnosis by the liver biopsy or by the bone marrow culture or blood culture. Not only the serology is efficient for the diagnosis, and we have to keep in mind that the treatment usually depending on the doxycycline for more than twice daily for 6 weeks, plus streptomycin. It is not readily available now, so we can use the gentamicin or rifampicin for 14 to 21 days, which is the treatment of choice now. Now we are moving to the second section about the biliary infections, and I think the acute cholangitis is one of the important infections that we can face in our practice. Usually it is secondary to biliary stasis and biliary obstruction. Until we have the drainage for the cause of the acute cholangitis, we have to know which regimen to use from antibiotics. I think the first line for treatment will be the piperacillin tazobactam, ampicillin sulbactam, or the third generation cephalosporins plus the metronidazole. And if it is not available, we can go for the fluoroquinolones from moxifloxacin, ciprofloxacin, or levofloxacin. And also we can make use of the ertabinins carbaminoms, including the imipenem, meropenem, and ertapenem. Usually, you have to start this medications, which has very good biliary secretion, till you will be able to do drainage for the biliary obstruction. Also, we have what we call HIV cholangiopathy. It is usually in the very advanced HIV disease for the patient, usually caused by the organisms like the cytomegalovirus or the microsporidium, and the treatment by the ursodeoxycholic acid may be useful for these patients. Also, we have the parasitic cholangiopathy, which is caused mechanical obstruction for the biliary system from the Scaris or the fasciola hepatica, and you have to go for the drainage or removal of the mechanical obstruction, plus using the proper anti-parasitic therapy for the causative organism. Now we are moving to the largest section of the talk today is to talk about the bowel infections. The bowel infections, we are talking about the gastroenteritis and actinomycosis. For the gastroenteritis, the most common cause of the moderate to severe diarrhea will be attributed for 4 pathogens: rotavirus, Cryptosporidium species, and enterotoxogenic E. coli, and the Shigella. And the inappropriate use of antibiotics with these organisms may cause antibiotic-associated diarrhea, and it will be precipitating factor for the antibiotic resistance. So we have to know when to use the antibiotic properly. Please keep in mind that we are defining the moderate diarrhea when it is 4 or more bowel motions, and for the severe diarrhea when it is 6 or more bowel motions, and all the causes of the bloody diarrhea will be encountered as severe diarrhea. The etiology, we have a wide range of causes, as you can see here, from bacterial, viral, and protozoal, with the most important 4 pathogens, as we have mentioned before. And if we are looking at certain age group, we can find that the rotavirus is mainly in the children from 6 to 18 months, and usually the Shigella from 1 to 7 years. And for the young adults, the Campylobacter will be encountered for the most of the causes of diarrhea. To go for the clinical presentation, we can make help from the epidemiological factors to know about the possible organism. Like the type of food can help us to know the possible organism. So we can say that with the fried rice, the Bacillus species are very common. For the ground beef, the enterohemorrhagic E. coli is very common. Also, we can have idea from or insights from the contact-related factors, like the swimming pool is a common cause for the Cryptosporidium, and for the childcare services is the most common cause for the rotavirus infections. For the intestinal manifestations, we are starting to compare between the small and large intestinal manifestations. For the small bowel manifestations, usually it causes mild mid-abdominal pain versus lower abdominal pain and rectal pain in the large bowel manifestations. The volume of the stool, it is large, and usually there is no blood or stool for the small bowel affection, but it is more common in the large bowel affection, and the sigmoidoscopy may be helpful in the diagnosis for the large bowel affection. To go for the specific presentation for a specific organism, for the bloody diarrhea, it is very common with Shigella, with the enterotoxogenic E. coli, and for the Salmonella, Campylobacter, and the chronic diarrhea is common with the parasitic causes like the Cryptosporidium and the Giardia, and for the abdominal pain, it is more common with the Zika toxin-producing E. coli and Salmonella, bloating and cramps common with Giardia, and so on. So we are now moving for the algorithm for the diagnosis and the management, because we have to know that 90% of the causes of acute diarrhea will fall in the idea of no studies and no treatment. So you have to know when to go for the studies and when to go for the treatment. When we have high fever, tenesmus, bloody diarrhea, dehydration, or prolonged diarrhea more than 2 weeks, you have to start for testing. Starting by obtaining fecal specimen to examine for the leukocytes, and it is not always there because leukocytes may denaturate, it is not stable, so we can use the lactoferrin for identification of having leukocytosis in the stool. If yes, you have to order the culture for Shigella, Campylobacter, enteroinvasive E. coli, or enterohemorrhagic E. coli. If no, so you have to order the culture for Salmonella, Yersinia, Enteromonas, or the enterotoxogenic E. coli or enteropathogenic E. coli. I have to stress here that is nothing called general stool culture. You have to order a culture with a specific order. You need a culture for a specific organism to help the microbiologist to help you to reach the diagnosis that you are searching for. And usually we are thinking about the idea of using antimicrobial therapy till the culture is available. So which antimicrobial therapy that we have to start with? I think the indications for antimicrobial therapy will be with the bloody and the mucoid stool plus fever, because if you have bloody diarrhea without fever, you have to think about the enterohemorrhagic or Shiga toxin-producing E. coli, which may be more severe with the use of antibiotics, and it may precipitate the complications like the hemolytic uremic syndrome. So when you have bloody diarrhea, mucoid stool plus fever, and shigellosis symptoms like fever, cramping, abdominal pain, and tenesmus, also for the febrile diarrhea accompanied by bloody diarrhea or prolonged fever, you have to go for empirical anti antimicrobial therapy, and for also the immunosuppressed patients with bloody diarrhea. For the empirical antibiotic therapy, we usually use the fluoroquinolones and azithromycin. Also, we can make use of the rifaximin, but it's only for the non-invasive bacteria. So it is not indicated with any patient who is presenting with bloody diarrhea. Here is the doses for the antibiotics that we have been suggesting. And after we have the result of the culture for the Campylobacter, the drug of choice usually is the azithromycin. And for non-typhoidal salmonellosis, we can use the sulfamethoxazole trimethoprim, but is only indicated for the children smaller than or younger than 3 months of age, and for the elderly with atherosclerosis more than 50 years old with atherosclerosis or immunosuppression or hemolytic anemia. Usually the azithromycin, ciprofloxacin, or ceftriaxone will be recommended for shigellosis and also for salmonellosis, and doxycycline is the treatment of a choice for the Vibrio cholera infection nowadays. Here is a table showing a lot of the possible organisms that may cause the infection and the first line treatment for this suggested infection. And we have to say that metronidazole and vancomycin are very important medications for patients suspected to have Clostridium difficile infection, especially with the prolonged antibiotic use or prolonged hospital stay. We have to give an idea about the Shiga toxin producing E. coli because it is very serious. You know, it is usually occurring in the young children and elderly, and it may precipitate hemolytic uremic syndrome. And the problem is this type of infection may be exaggerated, and the side effects may occur more with the use of antibiotics. So always think about the Shiga toxin producing E. coli when you have a patient presenting with bloody diarrhea without fever. Also, we have to know that the low platelet count or the direct blood film showing fragmented RBCs may be one of the tools that will help us to diagnose the hemolytic uremic syndrome early, and we have to know that it usually arises between 5 to 13 days of the onset of diarrhea. Traveler diarrhea is another very important thing to know, and you can see here that in the map, I think all of Africa can be considered as a risky region for development of traveler diarrhea, and it is usually caused by different types of E. coli, particularly the enterotoxogenic E. coli and enteroaggregative E. coli, but also the Campylobacter can be encountered in the causes of traveler diarrhea. So when we are thinking about the traveler diarrhea, we are usually not rushing to using the antimicrobial therapy unless we have patient with bloody diarrhea and fever. So we have to think about Campylobacter and start the azithromycin, or you have prolonged fever and moderate to severe symptoms, so you have to use the ciprofloxacin or rifaximin. Now we are moving to the extraintestinal manifestations of the bowel infections, which are common, and we have been just talking about the hemolytic uremic syndrome that may occur with the enterohemorrhagic E. coli. Also, we have the erythema nodosum or xerothenia, and the reactive arthritis with the Campylobacter jejuni, and a lot of causes like the iron deficiency anemia and the vitamin B deficiency anemia with the parasitic infections. Also, the Guillain-Barré syndrome, was very well defined with the Campylobacter jejuni, but it is not a very common presentation or not very common complication for its infection. Also, the blood culture and general test will be helpful for the diagnosis when we have patient with septic findings, with suspected enteric fever, with systemic manifestations, or is immunocompromised. And please keep in mind that Vidal test is not indicated anymore. Usually, we are diagnosing the enteric fever, which is a systemic infection, depending on the blood culture, not on the Vidal test. And for sure, the repetition of the hemoglobin, platelet count, electrolytes, and blood urea and creatinine will be helpful for the diagnosis and identification of the hemolytic uremic syndrome early for the diagnosis. For the intestinal complications, it is very common to have the hemorrhagic colitis with the enterohemorrhagic E. coli, Shiga toxin producing E. coli, Campylobacter, Shigella. Also, the toxic megacolon and intestinal perforation may occur with the same organism. And at this time, you have to go for the blood cultures and systemic antibiotics, and also for imaging. Regarding the role of endoscopy, we have to know that endoscopy is not recommended in most of the causes of acute and chronic infectious diarrhea. And it is usually be helpful, the sigmoidoscopy may help us for diagnosis of the infection related to the Shigella or for strongyloides or other causes of the parasitic infection. Also, the upper endoscopy with aspirate from the duodenum may be helpful for the diagnosis of giardiasis. Also, the role of imaging, like the CT, only limited for the patient who is presenting with fever, despite he is starting antibiotic therapy, or for the patients may have invasive Salmonella enterica or Yersinia infection, so they are at high risk for having systemic infection and valvular infection, so we may go for the CT at this type of patients. Now we are talking about the management for the acute, prolonged, or chronic diarrhea. The management usually for the acute diarrhea ranging from the proper hydration, proper dieting, starting antimicrobial therapy, but also we have a rule for the anti-diarrheal agents, especially for the patients with traveler diarrhea. If you have a patient with traveler diarrhea presenting with moderate to severe infection, but without fever, you can combine the loperamide plus the antimicrobial therapy. It shortens the duration and help the recovery rapidly. For the management of chronic diarrhea, it is different here. When you have a patient presenting by diarrhea for more than 1 month, so you have to think that the infections are not usually a very common cause of the chronic diarrhea. Usually we can encounter the parasitic infections like the Giardia, Cryptosporidia, and Cyclospora, and don't forget about the intestinal tuberculosis. We have a lot of causes about the chronic diarrhea. It is not the situation here. I think you can go directly for this algorithm. If we have a patient with chronic diarrhea, we can start by going for the colonoscopy, fecal leukocytosis test, and occult blood and stool, and imaging. If it is abnormal or showing the specific cause, it's okay. If no, so you have to think about malabsorption syndromes, pancreatic causes, and small intestinal bacterial overgrowth, and even IBS. So if we have pancreatic causes, we will go for the imaging techniques, AOS and ERCP. It is not the case here. If we are talking about the small bowel infections, so we have either luminal causes like the small intestinal bacterial overgrowth or the bile acid diarrhea, or we have enteropathy. The most common cause of enteropathy is celiac disease, but also lymphoma, Crohn's disease, amyloidosis. And from the infectious disease point of view, you have to think about intestinal TB and Weber disease. Here is a picture of the giardiasis and the pathological examination after biopsy taken from D2 by endoscopy. For the intestinal tuberculosis, also it is the same for the hepatic tuberculosis. It is either primary infection, usually affecting the distal ileum and cecum and causing a mass and lymphadenopathy, or it is a hematological spread of the infection as a part of the miliary TB, so it causes a lot of ulcerations all over the GIT. As you know all, the diagnosis of intestinal tuberculosis is usually challenging, and you have to combine a lot of things from the clinical picture and from using the endoscopy, searching for ulcers or strictures and so on. And also keep in mind that the tuberculin test is not always positive for the patient presenting by intestinal TB, only in 88%. And also the coexisting pulmonary TB only in about 65% of them. So you have to suspect the intestinal tuberculosis even in the absence of the positive tuberculin test and the absence of coexisting pulmonary TB. The Weber's disease is one of the important infections. It is a rare infection, but you have to keep in mind it is caused by Trifirima webeli, which is a gram-positive, non-acid fast periodic acid Schiff positive rods. And usually we think about the Weber's disease when we have the pentad of arthalgias, diarrhea, abdominal pain, and weight loss. And for the diarrhea, we are thinking usually when we have a malabsorptive diarrhea. Usually the diagnosis can be achieved by the upper endoscopy and the biopsies from the small intestine to be stained by the periodic acid Schiff stain. And for the treatment, we are using the penicillin and ceftriaxone to be followed by maintenance therapy by the oral trimethoprim methotrexate and sulfamethotrexate for about 1 year. The last cause of the bowel infection is the abdominal actinomycosis. It's a rare infection characterized by chronic indolent course and symptoms like fatigue, fever, weight loss, and abdominal pain. And usually it can be diagnosed by the CT, showing its infiltrative nature. And we can do the diagnosis also by detection of the sulfur granules or in the culture or in the histological examination. The treatment also by the penicillin is the preferred choice for the treatment for 6 to 12 months, and for the other complications like development of abscesses or fistula, we have to go for surgical management. So we have finished the bowel infection, which is the largest part of this presentation. Now we are finishing with the peritoneal infections, ranging from tuberculosis, SPB, and bacterial peritonitis. For the TB peritonitis, I think the ADA is one of the most important diagnostic tests that we can use, because in the level from 30 to 39 international units per liter, it will be helpful to differentiate the TB-related ascites from the other causes of ascites. And for the treatment, we always using the same regimen. It may be more prolonged to go from 6 to 12 months, but we are following the same regimens we have discussed before in the hepatic tuberculosis and intestinal tuberculosis. Spontaneous bacterial peritonitis, one of the most common infections that you are facing with the people who are living with liver cirrhosis and developing ascites. The usual bacteria is E. coli, and the diagnosis usually based on the aspiration and detection of polymorphs more than 250 cells per milliliter, in absence of other causes of peritonitis. Usually, you are starting treatment by cefotaxime or the quinolones, because they have very good concentration in the peritoneal fluid. And if we have nosocomial SBB, we have to go for the extended spectrum antibiotics like carbapenems and piperacillin tazobactam. And also keep in mind that we have to know that we have to follow the guidelines for using the prophylaxis for SBB for the indicated patients according to the shown guidelines. Secondary peritonitis is usually a complication of surgical procedure or complication of intestinal perforation, and its diagnosis also by having peritoneal fluid with TLC count of more than 100 cells per cubic millimeter. I'm sorry, and positive cultures. And most of the peritonitis causes usually caused by gram-negative or anaerobic infection. So as we have mentioned before in the liver abscess, you have to start empirical therapy by using antibiotics covering the anaerobes and the gram-negative infections till you have positive culture results. And finally, we have the last section. We have talked about the Weber disease. So we have what we call biliphlebitis, which is the infective suppurative thrombosis of the portal vein. Usually, it can be predisposed by diverticulitis and appendicitis, and it's usually caused by organisms like Bacteroides fragilis and E. coli, presenting by abdominal pain, fever, and are the most common presenting symptoms. It will be diagnosed by imaging techniques, ultrasound and Doppler. For sure, we may need the CT scan. And for the treatment, we have to combine the empirical antibiotic therapy using the metronidazole for the anaerobic coverage and the third generation cephalosporins or fluoroquinolones like moxifloxacin, ciprofloxacin, and levofloxacin for 4 to 6 weeks. But don't forget to add anticoagulation for these patients to prevent progressive of thrombosis, especially if the patient have persistent fever or progression of thrombosis. I think I have came to the end of my lecture today, and really I'm very grateful for all the organizing committee and all my professors here in the conference for this very good chance.
شكرا جدا، ما شاء الله محاضرة وافية عظيمة. في أي سؤال؟ حد يقدر يسأل أحمد أي سؤال؟
ممكن أسأل سؤال؟
ممكن. دكتور سامي؟
دكتور أحمد سعد.
أهلا دكتور أحمد، اتفضل يا دكتور أحمد.
ازي حضرتك؟ ما شاء الله جميلة. تسلم ايدك، محاضرة جميلة فعلا. بالنسبة بس للسي دي في سيل دلوقتي IDSA جايد لاينز حتى الفيرست لاين للمايلد ديزيز الفانكومايسين اور فيداكسومايسين if not available it will be metronidazole، يعني مش حاطين المترونيدازول كفيرست لاين. حتى في الاي في يقول لك ابدا بالفانكو 500 ملغ في السيفير كيسز 500 ملغ فانكومايسين اورال every 6 hours or rectal retention enema بلس الاي في مترونيدازول. فحاطين المترونيدازول يعني ما هواش الفيرست لاين، حاطينه الترناتيف يعني. تمام. شكرا جزيلا.
شكرا يا دكتور احمد الفاليبل كومنت.
شكرا دكتور احمد سعد وجزاكم الله كل خير. تعبتوا؟ مين تعب؟ مين تعب؟ دكتورة أميرة مين تعب؟ جميل تمام. إذا كانت برلين، عارفين برلين؟ برلين عملت ايه؟ ايوه برلين عملت مهرجان برلين الايه؟ سينمائي. وفينيسيا عملت ايه؟ مهرجان فينيسيا السينمائي. احنا بقى هنعمل ايه؟ مهرجان الجاسترو انترولوجي السينمائي. روعه. بس مش هيبقى مهرجان لوكال، احنا كل مهرجاناتنا ايه؟ انترناشونال طبعا، اكيد طبعا انترناشونال.
لا ناسا بس الليبتوسبيروز.
لا ليبتوسبيروزس ايه بقى يا دكتوره اميره بقى خلاص. احنا الدكتور محمد نجيب هينقلنا نقله حضاريه، جايب لنا من 4 اماكن من العالم جاسترو سينما. معانا دكتور محمد عثمان،
والدكتور احمد كردي والسيمبوزيوم الرائع. وهنخش على التسالي.